Hey guys, I just wanted to do a review of our couple past week's discussions. First of all, I felt like I kind of needed to get after you guys on email because opened up the discussion board, and there really was one post I think by Pilgrim for this week's on Saturday. So see if we can get things going a little bit earlier during the week. I know I put up a lot of stuff to read and go through, but part of being in the residency is we really want you to spend time. Reading, reflecting, understanding the literature, discussing it. And this is really our opportunity to do that. Of course, we'll do that when we come together during the weekend intensive. But I want you to put in some time during the week as well. So try to stay on top of that as best as you can. If something comes up, just shoot me an email, let me know, if you're whatever, you're sick or having a bad week or you got stuff going on, just so I'm aware of that. Like, for example, I know that Kim's away right now. So our discussions, the week 2, we kind of talked about like a case study involving a patient with directional preference. And then week 3, we talked about spinal stenosis and also motor control exercises. So I think all your posts, you guys are doing a good job on it, and and the idea that I really want you to get through is to look through some of the materials that are posted, think about these cases or the questions that we ask, and then reflect on your own practice. Are there things that you're doing that you could change? Why do you make the decisions that you do, whether it's a diagnostic test or using certain interventions? And I think you guys are really capturing that well, and I might ask you some questions to sort of stimulate that as well. It's like, oh, why would you use that test for that patient? Is that something you just do routinely, or is there a good reason for that? I think couple of things, like in that one case we talked about, patient basically had acute back pain, and some of you guys are saying, well, I might do strength testing of the hip, which isn't necessarily wrong, but at that time, is it relevant? Are you actually going to get any good information from that? Patient's in a lot of pain. Does it matter how strong their hips are? And are you going to start aggressive like hip strengthening interventions right off the bat? Particularly if this patient has a directional preference and we're maybe going to do more of like a extension-oriented program, at least to get their symptoms down, then maybe as we're moving into stage 2, we want to start identifying these functional impairments, be they strength, be they motor control. That's when we might transition more into looking at those things. So think about the staging of your patient. Where are they at? What is your priorities? I'm going to say that guy that came in week 2 would be stage 1, meaning get his symptoms under control, get him feeling better, rapidly move into to like a stage 2 where we're starting to work on strength, motor control, endurance, all those things. So think about that with your patients. What's your priority with that patient, and kind of tailor your exam to that. Lots of good discussion on spinal stenosis and kind of the older adult with back pain. I think we'd all agree that's a challenging population to treat, given the number of comorbidities, psychosocial factors, and also maybe the cultural or patients' beliefs in that population, where they're maybe been led to believe that it's all of their back pain is due to a structural problem, particularly if we're getting patients that are referred from surgeons or pain centers, those kinds of things. That can be really hard to shift that patient's focus away from, I need something to improve the structure of my back to get better, into more, I need to take an active approach, change my lifestyle, work on exercise and those kinds of things, rather than I need pain relief or I need a surgery or I need an injection in order to fix this structural problem. So that can be quite tricky, but I think that's something that we need to explore with these patients, at least from at a very basic level, to understand where they're coming from. Even if we can't change their beliefs, it's helpful to understand that so we can kind of maybe work around it. The second part would be, I think, we may be a bit too conservative with these patients. The older patients really need to be exercised and worked hard in order to make improvements, and maybe the dosage of our programs isn't high enough. Part of that could be the patient isn't tolerant to that, or they're not adherent, or their expectations, but it's in their best interest to get into a program where they are working on things like strength, aerobic endurance, balance, all those things that are important as you get older. and probably even more important as you get older, because that's where we start to really see a functional decline in their quality of life, and leading to mortality and all those kinds of things. So I think if we approach our older adult patients from that standpoint and really look at more of those lifestyle changes, and trying to get them active and stronger, that will be very beneficial. The hands-on part of it could be an assistance with that, getting in there and helping them to, gain more mobility in their lumbar spine or their hips or their thoracic spine. And as long as there's not contraindications or red flags, there really shouldn't be any safety issues with applying, graded manual therapy, even doing some manipulative procedures for these older adults, as long as there's not like bone mineral density or those kinds of issues. So the bottom line would be, let's not undertreat these patients, and let's see if we can kind of work around their belief system. And then finally, the motor control part is definitely a kind of a favorite topic of mine, just because I used to do a lot of that kind of stuff, whether taking more of like the work on your transverse abdominis approach, or more taking like, let's do planks and side planks and all that. And I think for some patients it was fine, and they did well with that, but you have to ask yourself, what is the carryover to function? If you work on these things with patients, does that actually improve the way they function and move in daily life, in their upright tasks? And that's kind of that cognitive functional approach is, can we actually help them to change the way that they move and very rapidly integrate that into functional activities? It's a little bit more of a tricky coaching or cueing to do that, but it does seem to have much more rapid changes that you can see. So instead of, our patient that we talked about, instead of just like, all right, we're going to give you a program, we're going to do side planks, we're going to do whatever it is we're going to do maybe on the table, and then assume that that's going to help him get back into his job. We say, okay, tell us what you can't do. Let's look at that movement. Let's analyze it. Is there a way, is the way that you're doing it stressful on your back? And can we change the way that you do it? And then ask them, how does that feel? And see if they can kind of start to explore that movement. I also sent you guys that blog this morning, which I thought went nicely with what we were talking about, where you're kind of guiding patients to explore how they move and be mindful of it, which kind of sounds new agey, but it's just a way of getting them more on board with the task, rather than, all right, this is how you have to do it, and it's got to be rigid, it's got to follow these rules. It's more, how could you work this out in this particular context for this particular activity? Because there's so many different ways you can do things, so many different contexts, activities. So helping a patient start to figure those things out, I think, is beneficial. We'll talk more about that and practice some stuff for that on the weekend as well. So keep it up, guys. I'm going to stay on top of you to make sure you're getting this done, getting everything you can out of this. Hopefully you're enjoying the readings. This is definitely, lumbar spine is a hugely important topic for our practice, because we always tend to see patients with back pain. In the coming weeks, we're going to talk about looking at lumbar radiculopathy. We're going to talk about pelvic pain and that kind of stuff, and also psychologically informed practice. So stay tuned, and I'll talk to you later.